Okay, good morning and welcome to everybody who's joining in today. My name is Jamie Wheaton. I'm a physiotherapist, and more specifically, I'm a pelvic floor physiotherapist at Donna Sarna Physiotherapy. I'm going to be talking today about Diastasis Rectus Abdominis, and I'd like to first and foremost say thank you to the Manitoba Fitness Council for inviting me here today and for talking about this really important topic. This is me and my nephew, Benjamin. He's probably the most important person in my life right now. This is us in Mexico swimming and us in Cinnabon Park last winter. I graduated in 2008 with my Bachelor of Physiotherapy at the University of Manitoba, and almost right away in my career I started delving into pelvic floor physiotherapy and taking my first set of courses. At this point in my career, the bulk of the patients that I see are of pelvic floor in nature. They have some kind of pelvic floor dysfunction. That ranges anywhere from men and women, prenatal and postpartum ages. I treat any number of sexual dysfunction and vulvar and penile pain syndromes. I also treat menopausal women, again, because of the same issues. Because of such a large recognition of the problem with abdominal separation, I have gotten into doing a lot of treatment with this, and I recognize that it is not identified enough in the general public, and I'm having a lot of patients come to me and ask me how to fix this. So hopefully what you're going to learn today will enable you to better treat your clients as they come in. The anatomy review that we're going to touch on is going to be quite quick and fly through. I'm assuming that most of you have quite an extensive knowledge of muscle and skeletal anatomy already, so I'm drawing on that, and I would encourage you to have some anatomy books open as we go through this so that if there is questions, you can certainly review this on your own time. Of course, I'll really clarify what a diastasis rectus abdominis is. I'm going to show you who the most likely clients that you'll see who have this and teach you how to assess it properly, and then hopefully offer some insight into treatment strategies and exercise prescription, although you'll see there really isn't any kind of magic recipe, just like there isn't for anybody that you see for any problem. We'll talk about prognosis, and then hopefully there'll be some kind of questions at the end, although I'm not really sure that'll be happening. All right, very good. Okay, so just to touch on the bony anatomy of the torso in general, remember the thoracic spine has the 12 vertebrae, 12 sets of ribs on each side. The sternum and xiphoid process create attachment zones for the abdominals. The lumbar spine with 5 vertebrae, the innominates, including the ilium, ischium, and pubic ramus, the sacrum and coccyx, and then the femurs. These all of these bones create really important attachment sites for the whole torso and core in general. When you start looking online with diastasis rectus abdominis and how to repair it and pelvic floor dysfunction, you come across a lot of talk on the deepest muscles, or the core 4. They are probably the most important concepts that you need to understand with respect to diastasis rectus abdominis. The pelvic floor being at the very bottom, the diaphragm at the top, multifidus at the back, and the transversus abdominis wrapping from back to sides to front, creating a whole big canister. This, or cylinder. The cylinder is important because it's how we stabilize the rib cage and the pelvis during movement, and it also maintains an intra-abdominal pressure. That intra-abdominal pressure fluctuates, and it needs to be able to fluctuate in order to maintain urinary and bowel continence. It helps us to expel our substances like vomit if we cough or through a bowel movement, and it also helps to allow us to generate pressure for a pushing during delivery of a baby. Again, like I say, brief review. To the left here we have the external obliques, which have been cut away to reveal the internal obliques. Note the direction of the fiber pull, and also note where they come to the center line and attach through fascia. and then moving on to the rectus abdominis from the xiphoid process and ribs all the way down to the pubic ramus. A little deeper to the picture to the right, we're looking at the TRA or Transversus abdominis muscle, and then a really important structure, the linea alba, running from the xiphoid process all the way down to the pubic symphysis. The linea alba really is a fibrous piece of connective tissue that creates the attachment point for all of these muscles. It is not muscular, it's not contractile, it is fiber, it is connective tissue. This is an important concept that you need to understand for diastasis rectus abdominis because it really is a stretching and thinning of the linea alba. Here's our transversus abdominis muscle, really important muscle with respect to control of the torso and control of intra-abdominal pressure. Attaching from the posterior aspect, the thoracolumbar fascia and lumbar spine, wrapping sideways, laterally, all the way to the front. Anteriorly, it attaches to the xiphoid process and pubic symphysis. So the origins are the cartilages of the lowest 6 ribs, iliac crest, inguinal ligament, thoracolumbar fascia, all the way inserting medially to the linea alba and pubic crest, as I said. So kind of completing the canister. Again, there it is, wrapping from back to front. I'd like to just make a note here so that you're really envisioning how these muscle fibers will contract. When they contract, you can see the left half of the muscles will draw on the linea alba, pulling to the left, and the right half will pull on towards the right, again drawing from the linea alba. So the action that it actually provides is a compression like a girdle. So the upper portion, because it attaches to the sternum and to the ribs, actually depresses the sternum, especially with an exhale. So if you wanted, you could actually use the stimulus of an exhale or a forced exhale to engage this muscle, and you should feel on your clients that their ribs come down or inferiorly and medially when they exhale. And when they engage the transversus abdominis. With a weakness of this muscle, it'll bulge anteriorly, and you'll see, like this kid on the left, you'll see that they're not girdling themselves, they're not pulling in, and that's because perhaps the transversus abdominis is weak. Just briefly touching on some of the superficial layer muscles because they are relevant in our anatomy for our core. Glute max, the adductors, the thoracolumbar fascia, and of course the lats, they all contribute to a whole closure sort of system of the core. And then more anteriorly, again, we're remembering thoracolumbar fascia with lats, wrapping anteriorly external, internal obliques, and then the rectus abdominis, of course. So the reason I bring up those more superficial core muscles is because with the use of these muscle and fascia system, we can create a concept called force closure. This is a concept that's really nicely described by Diane Lee. She's a physiotherapist out of, I think she's out of Alberta. At any rate, she has a very good book called The Pelvic Girdle. I encourage you to look into that on your own time. But force closure is essentially the concept where stability of the core and spine is generated by compression from muscles and fascia tension. So when we look at a posterior oblique system, we're looking at lats and thoracolumbar fascia and glute max. When they co-contract, we have this sort of diagonal cross fiber compression of the SI joints. And anteriorly, the anterior oblique system is the internal external obliques, and I would argue also the transversus abdominis, the abdominal fascia, pubic symphysis, and then also the adductors. So again, when these muscles co-contract, we end up with a closure, forced closure of the anterior component of our core. So this is really important in our purposes today because we're talking about the abdominal fascia and how it plays a part. And in a nutshell, that is what a diastasis rectus abdominis is, or abdominal separation. It's the separation of the abdominal muscles into the right and left half. have, and it's the stretching and thinning of that linea alba connective tissue. Pretty annoying problem to have and very, very common. So who are your most likely clients? Mainly it's going to be your pregnant and recently postpartum women. Moda et al. In 2014 did a study, and what they found was 100% of women in the third trimester actually get a diastasis rectus abdominis. That's a pretty scary number, but that number does fluctuate a lot throughout the research. I've seen anywhere from 60 to 100%. I chose to include 100% in this conversation because clinically I've actually never seen anyone in their last stages of pregnancy without a diastasis rectus abdominis. So I wanted that to really hit home with everybody. It's very, very common, and it does seem to be a more significant problem. This happens because of mainly hormone shifting. We get a subsequent tissue laxity, decreased estrogen and progesterone, increased relaxin, and it's kind of the relaxin is really the culprit here of why this all ultimately stretches. Because of weight gain, and because of the baby growing, we get a center of gravity shift, and subsequently the muscles pull differently than they normally would. Women with multiple children will have a repeat linea alba stretch, and it's really the same concept as a repeat shoulder dislocation or ankle sprain. This is a patient of mine to the right in the red panties here. She is not pregnant. She's about 10 months postpartum, and she can't pull her tummy in. No matter what she does, she can't pull it in. So we'll touch on this in a little bit. But it can be anybody. Anybody perimenopausal women will often have a representation of their diastasis that maybe they had when they were younger. But anyone who's overweight, including men, and even athletes with poor training of their rectus abdominis, if they continuously overwork their rectus and not engaging the Transversus abdominis, they can actually create a diastasis just by poorly training. This gentleman in the center here, he is again a patient of mine who presented with penis and testicle pain. And the reason he was seeing me, obviously, was for pelvic floor dysfunction, so I did my rectal exam. And if we envision that canister I was talking about, the core 4 muscles, I was evaluating primarily the bottom end of his canister. And with his pelvic floor, that all seemed very, very tight, and the tone was very high, which was why he was getting some nerve pain into his penis and testicles. But when I looked a little bit closer and looked at the rest of his canister, what I found was that he actually had an abdominal separation of several finger widths. And so that is likely the most likely cause of why his bottom end of the canister was in fact so tight. It's a compensation strategy for an open front part of the canister. So if his abdominals were open, the bottom part of the canister was working overtime to try to compensate for it. When we're assessing for patients, or in your case clients, I suppose, you want to know what are you listening for? What are they going to tell you, and what are some personal complaints that people have? Probably the biggest ones are discomfort in the low back, SI joints, thoracic spine, ribs, the kind of obvious ones. They might, if they're recently postpartum, they might say, oh yeah, I feel kind of vulnerable when the baby's bouncing around on my tummy. Or they might have difficulty lifting or carrying the baby. They'll complain of general weakness, and rightfully so. If their whole core is open and weak, what will end up happening is their upper extremities and lower extremities have a hard time drawing from that core. But probably the #1 complaint that I get is, how do I lose my mummy tummy? How do I get this abdominal weight gone? In observation, you'll look at them in standing, ask them to actually draw in their abs, ask them to let their tummy sag, and then ask them to pull it in. You'll note with the diastasis rectus abdominis, they might not actually be able to draw in their abdomen, and it might even gap or bulge more. As I said, if they recruit their rectus abdominis and it's a little bit open, the right half pulls to the right, the left half pulls to the left, and actually they bulge through the center. Seems bizarre, but that's what you'll see. And more than likely, they'll be butt grippers, or they'll be standing in a posterior pelvic tilt as a method of compensation, like my guy with the penis and testicle pain. In order to assess this, what we're doing is we have the client lie on their back in a sit-up position, so hips and knees bent, feet flat on the floor. You ask them to do a chin tuck and lift their head off the floor, only at just a few centimeters, maybe 5 to 10. No shoulders, it's not a full sit-up, you're just engaging the front wall of the abdomen, that's all. And with your fingers running horizontally, kind of pushing into the abdomen a little bit, you're measuring at the navel or at the belly button and a few centimeters above and a few centimeters below the umbilical curve. You're seeing how many fingers you can fit between the rectus abdominis with a contraction. And the research is showing a value of about 2.5 centimeters wide of a gap with a contraction is considered significant. So if that's what you're seeing in your clients, then you have to make a mental note that I need to be cautious with this client with respect to exercise. And you want to watch them for cheating when they're performing their exercises. The 4 biggest cheats that I see are bulging or doming or tenting up, rib flaring out, drawing in at the linea alba, or a posterior pelvic tilt. This is what bulging or doming or tenting looks like. These are exaggerated ones, they're very obvious, you can see here, but this is essentially where the intra-abdominal pressure is bulging up through the space where the rectus abdominis do not meet, where the linea alba is not creating a really strong connective tissue or attachment point, it's just bulging upward when they crunch up. Rib flaring out is another cheat. Again, this patient actually is a physiotherapist, and she is very bright. She's a Pilates instructor. She is fit. She has a diastasis rectus. But the funny thing is she knows she has this, but still can't control it, even with all of her education. So you just can't assume that somebody understands and knows how to fix it. You have to help them really quite a lot with this. At rest, her ribs are about 90 degrees of an angle. And then when I ask her to tuck her chin and lift up, keeping her tummy flat, because she's trying to keep her intra-abdominal pressure from escaping through the linea alba, what she's doing is using her obliques to depress the ribs down, and they're ending up flaring out. So if you're flaring out like this, you're not really using your transversus abdominis, and therefore you're not really going to allow anybody to get better with this. Drawing in at the linea alba is the same in concept as a bulging or doming out. It's often present with the rib flaring, but essentially you're still stretching the linea alba. It's just that it's stretching inward, not stretching up and out. And finally, butt gripping. The butt gripping is essentially a way of omitting the abs. And in a posterior pelvic tilt or in butt gripping, the transversus abdominis doesn't work as well as it does if the patient or client is in neutral. So in this top photo, I'm not sure if you can tell with the lighting, but she's in a posterior pelvic tilt here. Her pubic bone is pointing way up, whereas in the bottom picture, her pubic bone is quite level with her ASISs or her hip bones. We're going to go through each of these topics, but in terms of treatment strategies and exercise prescriptions, essentially what the general consensus is across the research is posture and function are of the utmost importance. More recently, there's a lot of talk on bracing, although that's somewhat controversial still. At any rate, the biggest focus will be on posture and function with these clients. If you do happen to see somebody in the first 6 to 8 weeks postpartum and they're coming to you immediately to try to lose weight and get their bodies back, just understand that recruiting the pelvic floor muscles and abdominal wall is really difficult for them to feel often. And really the focus is on posture in all their activities, even things like nursing, picking up the baby. This is where you can really add to their lives and help them from to prevent an injury. We're avoiding more than we're actually advising them to do. So avoid things like twist and lift, sit-ups, planks, double leg lifts. Those are all no-nos. Jumping, heavy lifting, any kind of vigorous activity during this time is not indicated. It's a time to really let the body recover. Do teach them good posture, a neutral pelvis, good breathing, because all of these are going to help avoid undue pressure in the abdomen. So how do we find neutral posture, neutral pelvis? I use the triangle all the time. The triangle is a really easy one to draw on. We're finding a triangle from ASIS to ASIS to pubic symphysis. The pubic symphysis is the point of your triangle, and the point of the triangle should essentially be pointing the direction of your torso. Also remember to preserve the lumbar spine natural curve. Imprint or reversal or flattening of the back, that's actually not neutral. We want neutral to be, again, as I say, preserving the lumbar lordosis. So here's an example. Neutral in the center here is a point of the triangle pointing straight down. In a posterior pelvic tilt, you can see she's really butt gripping, and that forces the pubic symphysis anteriorly. So the point of her triangle, you can see with the red arrow, is pointing in front of her, whereas in an anterior pelvic tilt, you have an exaggerated lumbar lordosis, and the point of the triangle is pointing behind her or posteriorly. The easiest way to, I would encourage you either to take a photo of this slide or else to write down the 1 to 8 kind of strategy. This is a handout that I give every single patient that I ever see. It is the 8 Qs to perfect posture. And essentially, this is the posture I want all of my clients and patients to be in when performing all of their exercises. So number 1 is chest proud, so lift the sternum up, and then tuck the chin down so that you're not elevating and kinking through your neck. Shoulders are down, not necessarily back, but down, and then the ribs are closed. So you'll find that as soon as you try to draw your ribs closed, you lose the sternum position, and that's just an inflexibility in the thoracic spine and rib cage. So you want them to work on this. Then after you've got that, you move down to your pelvis neutral, so finding that triangle, soft knees, so don't hyperextend or lock your knees. Belly button gently drawn in, this is sort of mimicking the TA action, and then again, glutes relaxed, so they're not overactivating in the glutes and therefore underactivating in the TAs. Some of the verbal cues that I offer to patients are draw in, close, ribs down, zipper your abdomen together, but never suck in. Please don't tell any clients to suck in, because they will suck air in and they won't be activating their abs. So important to cue for the pelvic floor here. If a patient or a client has just had a baby and that's the reason that they have a diastasis rectus abdominis, it's very likely that they have weakness in their pelvic floor. And so if you're not engaging the bottom half of their canister and you're only engaging the top half of their canister or the front, what you're doing is you're increasing the abdominal pressure, and that pressure is going to be pushing downward into their pelvic floor, and they can eventually get hurt by this and eventually have things like incontinence, prolapse, and other pelvic floor dysfunction. So it's important to bring up that bottom part of the canister. And how I usually encourage this to be done is start by relaxing in that neutral posture, and then encourage them first to slow the flow of urine or stop the passage of gas. This is general cues that I will try with patients. Otherwise, I might say something like, well, I would personally say, imagine squeezing a jelly bean up into the vagina or anus. You're lifting it up in. You might not use those same words with your clients, but you can simply say, imagine like you're pulling or lifting a grape into you, and leave it at that. If they really don't understand and they don't get where you're going to with this, I wouldn't just ditch it. I would simply either refer them to a pelvic floor physiotherapist or somebody who would have more credentials with actually talking about the pelvic floor. But don't just skip over it. As I said, that canister has a bottom, and they need to know how to turn it on. Also, the more comfortable you are with using these words with your clients, the more comfortable they're going to feel discussing any possible problems that they're encountering, and then you'll be able to direct them a little bit more readily. The reason all of this posture is so important is because of this concept. So this is a diagram of EMG findings, and essentially what it's showing is the posterior pelvic tilt and the subsequent activation of the transversus abdominis in that amount of pelvic tilting. So the first line where it says TRA transversus abdominis, you can see the loudest noise is being done when the pelvis is in neutral at the TA. So essentially, if you set up the pelvis in neutral, they're going to be activating the transversus abdominis the best. So to find it, let's all do this wherever you are in either your chairs or in standing. All you're going to do is sit up in really nice posture, so chest lifted, shoulders relaxed, feet supported, and glutes relaxed if you're standing. Just reach forward and lightly touch your knees, and then very gently press your hands or fingertips gently into your knees. Do you feel your ribs move a tiny bit? Do you feel your belly button draw in a tiny bit? Do you even feel your pelvic floor engage a bit? That's how, it's a very slight feeling of a transversus abdominis activation. It's very small. So the way we progress all of these exercises with this clientele, they have a very difficult time feeling their abs, and so the setup is so important, and the basicness of these exercises is so important. So the first step is really finding it, right? Just like we did just now, sitting up tall and pressing your fingertips into your knees. Another way that we can find it is lying supine or crook lying in a sit-up position like this and just turning on the abs. And the way we turn them on is by doing this kind of 1, 2, 3, 4 step. So number 1 is neutral pelvis with a triangle. Number 2, close the bottom end of the canister, so pelvic floor gently turn on. Number 3 is transversus abdominis on, or navel in, or belly button gently in. And then finally close the ribs. So encourage them to, if they can't do it that way, as I said with just thinking about closing the ribs, that's maybe where you can use an exhale to encourage them to draw their ribs together. So the progression is really doing this setup, turn on the abs 1, 2, 3, 4 in crook lying, or else if they can do that, you can turn them onto their side and ask them to pull their belly buttons in, pelvic floor on, transversus abdominis in, close the ribs. And then if they still can't find it in those positions because they can't feel any kind of tension with these muscles, then you can try turning them onto all fours in a 4-point kneeling position and asking them to go into neutral, turn on their pelvic floor, and then draw their belly button up against gravity and then close the ribs. Then they might be able to use gravity as a resistance so that they can feel what it is that they're trying to do. Okay, in this 4-point position though, if they actually have a separation of their abs where the rectus abdominis really is a fair bit apart, what's going to happen is gravity is going to pull the organs, adipose tissue, any kind of fat, down through that gap. So it's actually kind of like forcing the walls open even more. So we don't want to use any kind of inverted positions like this in gravity challenged positions unless they can close that gap, okay? Once they can feel it, once they can find it, we flip them back over and then we continue on with progressing exercises. So the bent leg fallout, heel slide, and a single leg dead bug or single arm dead bug, these are probably my most basic go-to exercises. Again, now I set them up in a neutral position. Number 2 step was close the pelvic floor. Number 3, pull your belly button in. Number 4 was close the ribs. Now they've got it. The bent leg fallout exercise is an exercise, this top picture, where you're holding one leg totally still, stationary. You have a pretend cup of tea, hot tea that you don't want to spill. And then your other leg is just ever so slightly and slowly, I suppose, abducting. That's why they call it a bent knee fallout, bent leg fallout, just as far as they can go while containing their pelvis in neutral and while holding their core stable. And then they bring it back up to return, and then they do the other leg, okay? Heel slide out, same concept. You're keeping your core stable, and you move the lower extremity. The dead bug is, again, same thing. Keep your core stable and lift your leg ever so slightly. They're not hip flexor or hamstring or adductor exercises. They're maintaining the core with movement. It's working. How do you turn it on?
We'll have her go into a neutral position with her pelvis, which is if we look at ASIS to pubic symphysis, that creates a triangle, and I want her to go into a neutral position. The triangle points, the pubic symphysis points down the direction of her torso. So she's going to tilt down ever so slightly, and then she'll almost arch her back a tiny bit. So this is what she looks like in neutral. To assess, I'm simply coming along the mid-sagittal line along the linea alba, and I'm going to ask her to tuck her chin and then lift her head without thinking about it too much. Lift up, and I can fit a couple fingers in between and rest. Come down at the umbilicus. Same thing, gently palpating inward. Go ahead, tuck your chin and lift. And now I'm closer to 2.5, maybe almost 3, and rest. And then all the way down here again. Same thing, tuck and lift. And that's, I cannot not even really even put one finger in there, so that's not rest. Now, most recent babies were how long ago? All right. So what we're going to work on now is the example of a bent leg fall out. So this is a Pilates technique. We're trying to teach her to recruit the abdominals properly, engaging the transversus abdominis properly. So if you go totally into your resting position first, you'll let everything sag. Now you can see she's almost in a posterior pelvic tilt here. So again, we find ASIS and pubic symphysis, and you drop the pubic symphysis down to the point of the So then she shifts and she looks like that, which is exaggerated, but this is what happens over time. So she's going to hold this position first. Finding neutral is imperative first. Then we do the 3 steps, turning on the core. So we're doing pelvic floor first on the inside, and maybe you notice that the belly button tuck in a tiny bit. The transverse abs, we think, draw these 2 bones gently together, and you can see her tummy pull in. That's perfect. You could also gently draw your belly away from the seam here. Keep that, and then we're thinking close the ribs down. She tends to gap them quite a bit, so drawing this inferiorly here. Good, and so now she's set that all up. This is really quite tight, and I'm happy with that. Now, we go to the legs where there's a teacup on the knee. It doesn't matter which one we do here. Let's pretend there's a teacup on the right knee. Keep your pelvis totally still, don't move, and let your left knee fall out just enough. But keep the pelvis steady. Keep it, don't move. And then keep your tummy in as you come back up. Up, 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 up. Okay, and then rest. Let everything sag. And you can see her ribs spring back up, her belly comes back down again. So,
okay, so that was it for that video. So essentially what I'm hoping that you were able to see was the fact that when she tried to move her leg, the struggle was essentially to hold everything perfectly still. And so the biggest take-home message is to set up everything first and then don't move as you move your extremities. And that's stability in a nutshell, isn't it? Then you move on to then keeping the abdominals tight with adding a little bit of gravity there. So in side lying, of course, gravity is wanting to pull the belly forward, but you're holding it back with your TA. So you're doing things like a clamshell on this picture down into the left, or a straight leg abduction. And then once they can do all of that, we add things in prone or under gravity. So I do with patients a prone opposite arm and leg extension. That's swimming in Pilates, if you've heard of it. But the point here is on this top picture, you're trying to make sure that you're not squashing the TA down. So I tell them to pretend they have a little robin's egg underneath their belly button and they don't want to squish it. A 4-point position is essentially the easiest form of a plank, and so this is where I would start patients, and you're just doing holding in this position. Again, you set up your neutral spine, then you do your pelvic floor and your transversus abdominis drawing in, and then close the ribs, and then just hold it in a neutral posture like this. With that same patient, when I asked her to go into a neutral spine, the top picture is what she did. She thought that that was neutral. And so this is where you can help your patients. Don't just give them the instruction and allow them to do it at home. Make sure that they show you, because you can see in this picture that at the top, she's not even sort of in pelvic neutral. She's way put in a posterior pelvic tilt. She's exaggerating her kyphosis. She's essentially doing like a crunch with her rectus abdominis. She's not actually engaging any other part of her abs. So when I showed her at least what's closer to neutral, this bottom picture, that was a struggle for her just to get into the position. So that's as hard as the exercise needs to be. And then you can start to really work with this from there. So now we're thinking about really strengthening. So things like crunches, wall squats, eccentric work. You can really be creative as long as they can get into neutral, do their pelvic floor, transverse abs, and close the ribs and hold it. Then they can basically do anything. Okay, a word of caution. If the linea alba is not acting as a stable insertion point for the muscles, then the external and internal obliques are generally going to flare the ribs, and the transverse abs will pull the linea alba wider. If you remember back to one of the first slides with the anatomy, the transversus abdominis, because of the way the muscle fibers orient, the right half is going to pull at the linea alba, pulling it to the right, and the left half is going to pull at the linea alba, pulling it to the left. So it's essentially widening the gap. This is going to create that indrawing or bulging out or rib flaring, which we need to avoid. Let's see if I can make this video work here. Rest. Now do a little mini crunch here. Yeah, and rest. Again, same thing, do your mini crunch, fine, and rest. And then now show me how your belly bulges. Yeah, and try to do kind of like a sit-up or a mini crunch here. Yeah, and rest. Show me a cough. Perfect. Okay, now do your best, just like we talked about, try to close up in the pelvic floor first. And flatten everything out, that's it, as you do a little mini crunch. So you can see, hold it there, you can see rectus kicking in here. There's no invagination, and there's no doming up. Good, very good. Sorry, the invagination is a word that's used to describe indrawing, so I never really touched on that yet. But at any rate, with this person, you can see how the fascia, the integrity there is just not the same as the other girl who I showed. In this case, this woman is 10 months postpartum, and it's just so hard for her to recruit her abs because it seems like no matter what she does, this it just pulls apart. So it was interesting, I don't know if you caught it, but when she initially engaged the pelvic floor, she had this weird bulging up in the abdomen. That seems so weird, but it's not. It's because transversus abdominis work with pelvic floor, which is why we use them together. And in her case, when she engages pelvic floor with TA, the TA pull apart, as I had just said. So it's creating an intra-abdominal pressure loss because that's just bulging up through that diastasis. So in her case, and in clients like this, we have no choice. We have to encourage them to use those muscles, the TA, and set it all up properly. But then in their case, they have no choice. They must incorporate some kind of a rectus abdominis pull or some kind of a flexion at the torso in an effort to shrink the rectus abdominis. And so that's what she did there. That's what I was trying to show. Once they can kind of manage their posture and hold everything in, then we're turning all of this into functional exercise. So we apply that perfect posture, like I say, sternum up, chin tucked, shoulders down, TA engaged, etc., with their transversus abdominis, with the squats, lunges, upper extremity work, lower extremity work, whatever you want to do, planks, side planks, all of that is okay. It's just that they must be able to maintain their perfect posture, their neutral pelvis, closed ribs, etc., without the bulging, without the gapping, without all the other cheats that I showed. So in a nutshell, they're not allowed to be bearing down or holding their breath or bulging, doming, tenting, rib flaring, no kind of indrawing or butt gripping. Essentially, if they're doing any of those things, they are exerting beyond what their transverse abs or their core can keep in neutral, and eventually they're going to hurt themselves, or you're going to kind of steer them in the wrong direction where their gap is not likely to improve, or it'll get worse, in fact. If you are meeting somebody who's in a condition like this where they just seem to continuously gap over and over and over, and they have that fascia that looks like the woman in the red panties, then we need to have caution, even with simple things like moving from lying down to sitting up. They can't just heave themselves up with their rectus abdominis. They need to turn to their side, push themselves up into sitting this way, and essentially avoid the use of the abs in a way. Similarly, even going from sitting to standing, they need to shimmy themselves forward in their seat first and then lean forward and push to stand up. Recently in the research, there's been a lot of talk on bracing and abdominal binding. I use this sometimes clinically. However, there's some comments that I'm going to make about it. But essentially, the main considerations are we have to continue to exercise and work the core for even with the brace on. Bracing is important, especially, for example, like with my woman with the red panties with the fascial loss. The integrity is lost there, and she just can't hold it in, so a brace is good for her. The wrap should be elastic to allow for movement and breathing, and they should not be experiencing any pressure downward into the pelvic floor, vagina, anus, rectum area with the use of the brace. They are everywhere. There's so many gimmicky ones on the market. You have to be really careful with what you buy. My advice to my patients is buyer beware. Take your measurements, check it out, make sure that you can return it if you're buying it online. There's two that I like that are on the market that I've sort of identified in red here. The baby belly band is, again, come from a physiotherapist in Alberta, Diane Lee. It's the baby belly band. That is for pregnancy. And then Bellies Inc., a group out of Toronto, they have sort of a breast exposed for nursing kind of tank top, which is elasticy to create a compression, and then further a compression wrap like a tensor bandage almost that goes around the lower abdominals to help hold them in. Again, these things you have to be careful that it's not increasing their abdominal pressure such that they're experiencing pressure downward into their pelvic floor. That's a problem. But you can even see Brooke Burke has one, so you have to kind of watch what you're buying. Some pelvic floor considerations, as I've talked about, pressure from holding your breath will push down against the pelvic floor or out between the abdominal separation. So make sure that you're instructing good breathing, let your air out, as you already know to do. And encourage a pelvic floor assessment if you or the client is feeling unsure about their Kegels or pelvic floor muscles and they're not sure what they're doing there. Encourage them to actually see somebody about it. Even once or twice will be enough to show them what to do properly. So again, if they're experiencing a worsening in bladder or bowel symptoms, any heaviness or downward pressure into the vagina, rectum, or perineum, or if they already know they have pelvic organ prolapse, then they probably should consult a pelvic floor physiotherapist, an OB, a gynecologist, to make sure that they do have pelvic floor competence. And maybe they need to discontinue their brace until they actually are stronger in the bottom end. Big questions in terms of prognosis. Will the diastasis heal on its own over time? Well, it depends. Basically, it does to an extent. always. The first 8 weeks are crucial for spontaneous healing, and the bulk of the shrinking happens in that first 8 weeks. But we have seen in the research that careful training, slow progressive training of the rectus abdominis and the transversus abdominis can lead to an improvement in the distance in the gap. Even if it's years later, we do want to incorporate TA and trying to improve shrinking there, and it does work. But can it get worse? Yes, as I showed, even men can get it. So they've never had a baby, so a lack of physical activity, menopause, weight gain, postural adaptations from jobs that are hunched over a desk all day. And again, as I say, poor training repetitively can give you one if you didn't already have one. So over time, all of these can lead to a stress on the linea alba, and then it can worsen or create a diastasis recti abdominis. In summary, there really isn't any absolute recipe for this stuff, but I would encourage you to start checking everybody for a diastasis. And the biggest lessons that I have here is posture is number one. It's very crucial. We have to start really slow and controlled with these exercises. And do not allow with your clients to have any kind of bulging or doming or loss of technique with the exercise. Don't just slough it off and move on to the next one. Really harp on how their quality has to be good. And bracing might be helpful with the population who can't seem to pull it in for themselves. The good technique really is neutral spine in the pelvis and end of the pelvis. Pelvic floor turns on, transversus abdominis pulls in, and you close the ribs. And that's it. So thank you so much for coming. Here's my personal email address if you need to send any questions for me.
Thank you very much, Jamie. That was very informative. I have a couple of questions just with regards to group fitness that I'm hoping that we can kind of get to. So a lot of us teach, or most of us teach classes in a group. So do you think that the process that you kind of went through is something that you could have people assess on themselves in a group fitness class?
Yes, you can. Often in pregnancy, because of the baby pushing forward, it's hard for patients to see that they have one. So a self-assessment can just be if you have that gap, if you have that bulging up in the center line, that's not the baby, that's the abdominal pressure escaping, and that is a diastasis rectus abdominis. So number one, you just know that it's there if you see that bulging. Number two is you can go through that crook lying position, put your fingers at the belly button and lift your head up and feel for a gap yourself. You can do that if you're postpartum or if you've already had your baby, but you can't really assess in pregnancy, but certainly postpartum you can.
And maybe even sending people home with a handout as to what to look for so that they could go home and look what they use a mirror or something like that. It might be helpful.
Yeah.
If you see someone in your class who has doming or flaring, what should you recommend doing? What is the referral process that we should be?
Good question. I would probably tell them sort of as an aside to avoid any of those exercises that you're doing that you see the doming, or if they notice it, make sure that they understand what it is that they're supposed to avoid. So if you know that they're supposed to be avoiding things that gap or bulge or rib flare or like the things that I talked about, and they don't know that, they will continue to do it. So the biggest thing that you can tell them is don't do the things that make you have that gapping, bulging, etc. And then you can offer them modifications to exercises. So for example, if you're doing crunches and they can't do one without it, as an example, you can show them the bent leg fallout. You can show them the heel slide or the dead bug, or show them how they can do a really slight crunch without actually creating a doming, and make sure that they understand that they have to pull their ribs down, etc.
Now, I have seen some pictures where people use a towel and kind of wrap it around the lower back and up to kind of pull things in while they're doing the exercises. What are your thoughts on that?
You know, I've tried it with so many patients, and I find compliance is low. And my worry, because of knowing so much about the pelvic floor, is that if that is increasing pressure too much, that is pushing down against their pelvic floor, that's not necessarily what I want. But it does have some validity behind it that if you're pulling the ties or the towel closer, technically it might be approximating the ends of the abs more closely together, and it may be giving them some assistance, but functionally it will not translate into any kind of improvement because it's just not a replicable thing in regular life. Right. So I don't use it a lot.
Okay, one last question. What about those that don't want to be singled out? So, for instance, especially if you're saying, you know, if this is a problem for them, then they shouldn't be necessarily doing this exercise. How do you think you would handle that? People who don't want to be singled out by thinking that they have an issue that they would be doing different exercises in their class for?
That is a really tough one, and unfortunately, I would really try to not slough it off and just say, okay, then continue on. I think helping them to understand the importance of this and how it can, and I would even say can and will lead to some kind of a dysfunction later. And the more they see that bulging, the more they see that flaring, the more they're actually pushing the abdomen apart and losing strength and basically widening the gap. So I think helping them to understand why they're being singled out is probably a good thing. And also helping them to understand the figures. They're not being singled out. I said that about 100% of women in their third trimester get this. So I think also, you know, encouraging them to realize this is actually a really common issue. You are not strange by no means to be singled out in this way. And so offering them something that they can do with good technique in the class is going to enable them to participate without actually having them feel singled out. They can do their own sort of thing while the rest of the class is going on.
Sorry, I know I said one last question, but I have one more question. So if it is going to reverse itself, what is the general timeline that happens, so that when you are assessing is there a general timeline?
Yeah, good question. I had actually adapted this presentation for a different population, but in a previous presentation I had commented on a maximal medical improvement. That's a concept in physiotherapy. MMI, or maximal medical improvement, is not deemed until after 1 year. And so when people ask me, is this going to get better? The first questions that I ask are, well, how old are your kids? Number one, that gives me a time of how long postpartum. Number two is, are you still nursing? Nursing, it has a way of kind of persisting with some laxity because of hormone fluctuation. And have you been working on this already the way I've shown for over a year? So if it's been, they're finished nursing, pardon me, I forgot to mention, they have their period back also, a regular menstrual cycle speaks to, again, their hormones being back to normal for them. Finished nursing, got their period back, they've been working on this for over a year, then I would say this is about as good as it's going to get. But if they haven't been working on this, even if they have their period back, even if they're finished nursing, I still would say, okay, well then this is where we start. We start doing this, and if after a year you're still at the same spot, then we start looking outside the box and seeing what else we can do. Or if in talking to them you feel like, I'm not confident that you understand what I'm doing, or I'm not confident that you're understanding the concept, or when you're contracting your pelvic floor, you and I are not feeling confident that you're doing it properly, that would be a time that you need to refer on to, say, like me, a pelvic floor physiotherapist who ties it all together and actually physically checks vaginally or rectally to make sure that they're doing all this properly. Then we can kind of say you're as good as you're going to get.
That is excellent. Thank you so much. I learned a lot today, and thank you so much from the Manitoba Fitness Council, and take care.
Thank you so much, Stephanie.